Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today we're continuing discussing some important rules in the clinical care tips category. Rule number 91. Have the epinephrine ready before you intubate. I learned this rule back when I was a Pediatric Emergency Medicine fellow from one of the PICU fellows at the Children's Hospital of Pittsburgh, and he used to say and used to tell me all the time that before he intubates a patient, he always has a dose of epinephrine ready to go, just in case the patient decompensates during intubation. So, as some of you probably know and possibly experienced, some patients do very poorly when you intubate them. And there are several reasons for that. I'd like to thank my friend Daniel Richman, who's an anesthesiologist who helped me understand and figure out the reasoning behind this rule. I've always said anesthesiologists are the smartest doctors out there. Daniel also happens to be a very talented musician, one of the best drummers I've ever met. So there are actually several reasons, my friend Daniel says, why people have cardiovascular collapse after intubation. One of the common reasons is the increase in intrathoracic pressure, which leads to decrease in venous return, which can lead to decrease in cardiac output. So if you have a patient that is already sick with sepsis or anaphylaxis or whatever it may be, and now his cardiac output decreases even further, it can really lead to some serious problems. And I've actually seen it happen intubating patients with asthma who go to cardiac arrest. Another reason is the positive pressure we provide that leads to further increase in intrathoracic pressure, which can be detrimental for someone, again, who is already hypovolemic or in septic shock, etc. Another factor my friend Daniel mentions is the fact that sedation medications, unfortunately, often leads to vasodilation in patients that are already critically ill and may be already maximally clamped down, and then medication relaxes their blood vessels even further, and they end up with very little venous return and, again, very decreased cardiac output. For those reasons, some patients upon intubation go into cardiac arrest or PEA and do very poorly. It is therefore probably a very good idea to have a dose of epinephrine just in case there's PEA or asystole shortly after intubation. This is, of course, related to rule number 39, which says a good ER doctor is always ready. Be a step ahead. So remember rule number 91. Have the epinephrine ready before you intubate. You never know if you're actually going to need it. Rule number 92. Utilize your resources well. So this, I feel like, is just a good rule for life. It helps me be efficient. It helps me take care of my patients better, and just a good skill to have. This rule comes into play in many ways, and I can give endless examples for it. One great example is the use of our HUC, Health Unit Coordinator. Possibly this person or this role has different names in different ERs. Generally speaking, the Health Unit Coordinator is often the first person the patient, parent meet when they check into the Pediatric Emergency Department. They are often located at the nursing station, and they are an essential member of the healthcare team. In our Pediatric Emergency Department, we have some really hard-working individuals that serve as health unit coordinators. They help me take care of my patient. They help bring patient in. They really help with anything you need. So sometimes I get a patient that was referred from the primary care office, and sometimes the primary care physician that calls us asks for an update about the patient or the outcome or the disposition. I must be honest and say I don't always call back because I don't always remember to do that. Sometimes I simply forget, or sometimes I just can't find the time. However, when I do call them back, they're always very appreciative that I give them an update of what's going on with the patient. Knowing that the PCP may or may not be available to talk right when I call them, I often give the number to the HUC and ask them to call the PCP while I go to see a patient or two and let me know when they're able to reach him. Since I carry a radio, the HUC can always communicate to me quickly, and I can easily take a break from my patient encounter and speak to that primary care provider who's waiting on the phone. That brings me to another resource I like using, which I find has a huge impact on my care and my efficiency, carrying a radio. So in our emergency department, we have those small radios with an earpiece that enable us to communicate with one another very easily. That piece of equipment makes me aware anytime a patient signs in, answer any question the nurses may have, and most importantly, It makes me aware if anyone needs me urgently for a patient that is decompensating or is not doing well. It is in that radio that I sometimes hear, "Dr. Ivan, can you please come to room 7 quickly?" As I mentioned, the HUC also let us know whenever a new patient signs in and which room they're in. So if I'm sitting with a patient giving anticipatory guidance and I hear that there's 3 or 4 or 5 new patients, that alerts me that people are waiting and I probably should move on a little faster. So that is another good example how you can utilize your resources, something small that can really help you be more efficient, more aware of what's going on in your department, and just simply provide better care for your patients. Another good example for this rule is utilizing child life. So I have been very fortunate to work in pediatric emergency department that have child life with very good coverage, not 24/7 of course, but definitely during the peak hours, and I can't tell you how many times they have helped me take care of my patients. They often sit with the kids, explain what the procedure is going to be like, and really put the parents and the patients at ease. They are a great resource, can help with efficiency, and just help provide better care for our patients. I'll actually take this opportunity to give a shout out to my child life specialist, Jesse, who's going to come on the show in a future episode to talk about the role of child life and how they can help us take care of our patient. So be on the lookout for a future episode with a child life specialist discussion. Rule number 93. You can always do more. So this rule is somewhat related to less is more, which I talk about all the time. It's probably a good rule for life, and it is true in many ways, but it is especially true in medicine and medication administration. A good example for this rule, when I'm about to do a procedure and the parents or the patient seem very anxious and ask about putting the child to sleep, aka sedation. I try to explain that sedation is a fairly serious ordeal with some risks and costs and much time spent in the emergency department, and I often offer to give the child some Versed first. By all means, Versed is not sedation, but sometimes it really takes the edge off, and I always say to the parents that if the child is still uncooperative or if the procedure cannot be done safely, we can always do more, meaning full sedation. I can start with some Versed. If the patient is not tolerating the procedure is unsafe, etc., you can always get an IV, give ketamine, and do full sedation. You can always do more. This rule is further exemplified when I actually do sedation. So as some of you probably know, the dose for ketamine for conscious sedation for pediatric patients is 1 to 2 milligrams per kilogram. So after I get an IV, we set the room, respiratory therapist is ready, I always start my sedation with 1 mg per kg. After administering 1 mg per kg, I assess the level of sedation. Is the patient aware? Or have we achieved a good level of sedation? And if we have, I stop with 1 milligram per kilogram and I do not administer more. Remember, you can always give more, but you cannot take away what you already did. Certainly, if the patient seems to be in pain, and sometimes I know that just by looking at the monitor and looking for tachycardia, you can always give more ketamine. But once you have some adverse outcomes from ketamine, which are not very common, you cannot take away what you already did. So remember, rule number 93, you can always do more. And that is it for today, guys. Thank you very much for listening. Let's review what we learned. Rule number 91, have the epinephrine ready before you intubate. Remember, there is always a chance of cardiac arrest or PEA. When the patient gets intubated, it's probably a good idea to have a dose of epinephrine just in case you find yourself in a resuscitation situation. Rule number 92, utilize your resources well. Think about what tools are available to you and what tools can help you give better care for your patients. Use what you have. Rule number 93, you can always do more. Remember, once a medication is given, you cannot take away the side effects or the possible adverse events. It's probably a good idea to go step by step, give the lowest dose that is likely to help, and see if the patient needs more. Remember, if a patient needs some help with the procedure, it's very reasonable to start with Versed as anxiolysis, and you can always go to full sedation if the procedure is not tolerated. So rule number 93, you can always do more. And that is it for today, guys. Thank you very much for listening. I appreciate it. I hope you can check out penrules.com. Please submit any feedback and let me know if there are any specific topics you would like to discuss in the show. I hope you have a good day. I hope you like the outro. The Red Hot Chili Peppers are one of my favorite bands and I love playing the music.